I am so sorry. We were having a fascinating conversation. I'm multiplying 7 minutes of being late times all of you. I owe you all a lot of time, so I apologize. I'll try to go quickly and efficiently through my slides and see how we do with that. So we're talking in this session about use of non-steroidal anti-inflammatory drugs, steroids, both oral and IV, IVIG, which almost everybody knows stands for intravenous immunoglobulins, and therapeutic plasmapheresis, as well as others. And others, the only one I'm going to mention is rituximab, but actually I think among our consortium, rituximab is losing a little bit of favor, and some of the other very strong immunomodulatory drugs, such as Cytoxan and methotrexate, others are being thought about. And we were just, in our conversation, we were just sharing that I think probably the next step for PANDAS clinical research really needs to be what is the next step after we've tried the things that have been shown to be effective, because at each of our centers and at each of the clinicians, they have a handful or more of children and particularly teenagers who are struggling with continued symptoms. So one of the questions that I cannot answer for you is at what point do we stop? And I'm going to take this sort of out of the PANS criterion for a moment into the world of autism, where, as I told you, I worked for a decade doing clinical research and trying to understand the risk factors for developing autism, as well as really understanding what the natural and the treated history was, and whether some of the complementary alternative functional medicine interventions, including things like chelation and others that are considered quite controversial in the States, whether those had any impact on the outcome for that child. Literally the sort of full course press that we learn early in pediatrics. When you have a really sick child, you do everything that you can to try and make them better. And what became incredibly clear was that therapies were started, and then they were never stopped. So I would see children who were 5 or 6 years old who were already on 95 so-called natural supplements, as well as a number of medications. They were on a casein-free, gluten-free diet. They were having all kinds of behavioral interventions, and their life just revolved around an illness that was increasingly becoming clear that it was neurodevelopmental, and that, in fact, for this child that I'm thinking of, they had had symptoms since birth. So in PANDAS, we don't have that situation. We have a child who's been the star soccer player or the teacher's pet, as well as everybody's favorite, and clearly going on to live the most wonderful, fully functioning life, who suddenly falls off the rails and becomes incredibly ill. And then you're left with a child who has chronic static or chronic relapsing and remitting mental illness. And the question is there still a fire underneath those symptomatologies, or are what you've seen more like you would see in an adult patient who has had a stroke? During the early period of stroke rehabilitation, what you're actually trying to do is to maintain functions that may have been temporarily destroyed by the inflammation surrounding that stroke site. But you come to a point where the stroke moves on. So that's a very discouraging way to start my talk. And the only reason I say it is because I've talked to a number of families who that's what your questions are right now. Do we do another round of IVIG? Do we do another 4 rounds of IVIG? So as I go through each of these today, I'm going to share some personal experiences and personal views, as well as point you to the guidelines. So the treatment of PANDAS for the first probably year that you're dealing with this illness is spelled out in excruciating detail in the Journal of Child and Adolescent Psychopharmacology, September 2017. It is available through PubMed Central, freely available now to you. You can print it out, take it to the doctor, you can read it, highlight it. I reread it last night. It is truly excruciating detail, and there is everything you could ever need to know. You can see the cast of characters that contributed to this. We actually met in person, and then Jenny Frankovic is everybody's heroine because she worked tirelessly for the next year and a half to turn that in-person meeting into something that everybody could agree made sense. I should have shown this slide before. I did have a conflict with yesterday's presentation, but I have no conflicts or disclosures relevant to today's recommendations around treatment. This was the research consortium. I think the picture that Robert took today hopefully will be better. You can't really see faces, but we all know who was there, and it was a wonderful, wonderful 2 days where we just had an opportunity to share cases and think together about what made good sense. And the thing that came out of that the most obviously was you have to divide the children into categories of severity. Now, Margot put up a brief picture of Jenny. I actually wanted to show this slide because every time you see a white slide with a red at the bottom that says Stanford University, I shamelessly stole that from Jenny. So please give her the credit for those slides, such as the next one, which is sort of a larger picture of where PANS and PANDAS belong within brain disorders in neurology and psychiatry, and that is a large group of illnesses known as the inflammatory brain disorders, where whether it's autoimmunity, it's systemic autoimmunity, or whether it's actually an inflammatory process. The leading cause of an encephalopathic process is actually an infection. You guys may have had West Nile a couple of years ago, herpes encephalitis, other kinds of viral infections that give you encephalitic processes are probably the leading cause of inflammatory brain disease. Then you run into a lot of other things, some of which become more common among adults, but in children, we go right to basal ganglia encephalitis and vasculitis. You saw Sydenham's and PANDAS there, but other infections can do the same thing, as can antiphospholipid antibodies, which are also a factor. So you look in those to try and get a hint of that. You might look at the mom's history of frequent miscarriages. Autoimmune encephalitis or diffuse cerebritis, the very first patient sent to us in our Sydenham Korea study was actually a little 10-year-old girl from Texas who didn't have Sydenham chorea. She had lupus cerebritis, and she had classic symptoms of chorea, OCD, and other things that we would now identify as Sydenham's. But when we did the complete medical workup, we found that she had systemic lupus erythematosus. She had some rather significant kidney disease at the time we first saw her. Limbic encephalitis, Hashimoto's encephalitis. There was just a meeting in New York last month where the autoimmune encephalitis groups, including the Hashimoto's group, and I think the NMDA has their own group. At any rate, they all got together to have a 2-day meeting on autoimmune encephalitis. We sort of invaded their territory to remind them to think about PANDAS and PANS, and it was actually a very productive time because every description they were sharing of what the experience as adult patients with autoimmune encephalitis was completely akin to what we experience in our children who have PANDAS and PANS, right down to the fact that they can go for weeks, if not months, with the wrong diagnosis or without an appropriate evaluation being made. So what is the evidence that PANS as a general category is an inflammatory brain disorder? Now remember, PANS, in my opinion, is a syndrome, but Dr. Frankovic has really assembled a nice literature showing that use of immunomodulatory treatments for a child who just meets the PANS criteria is appropriate on the basis of these findings. And that is her work, as well as that of Dr. Tienemann at the Stanford Clinic, demonstrating a strong association with a very specific allele on the HLA system, which determines your immune reactivity. The high rate of autoimmune signs and symptoms in the children with PANS, particularly when you see a child who has a new onset of back pain and fibromyalgia, sort of muscle and bone and joint pains at the same time as they have their onset of their neuropsychiatric symptoms. There's a much higher rate than expected of autoimmune disorders, particularly Hashimoto's encephalitis, among the moms and the aunts of the children with PANS. And then the fact that when you start looking for autoantibodies, which we talked about this morning, the profile not just in the serum for anti-brain antibodies, but also for anti-tissue antibodies, anti-nuclear antibodies, such as we described. It might be a predictor of response to IVIG. Preliminary imaging data showing the inflammation in the basal ganglia, inflammation of the blood vessels. There's actually a specialized MRI scan that can be done that looks at the emptying, and they're using it quite successfully in multiple sclerosis. Some centers are now looking to see whether we can do the same thing in our patients who are acutely ill with PANS. And just as an autoimmune encephalitis, sort of the catch-22 of if you respond to a treatment for an immune condition, you must have had an immune condition. Well, the same thing is true in our PANS cohort. We talked about this already, so I'll just move right into the first of which is how do you decide which therapy to use? And it's totally dependent, as is the diagnosis, on what that child's history is. What are their symptoms? What is the duration of illness? Not just what's going on with the neuropsychiatric symptomatology, but what else do they have happening in their bodies? So the review of systems is just as complete as it would be if the child was presenting with rule-out pneumonia. The severity of illness is the thing that we found easiest to group our treatments and to start thinking about, okay, I'm going to approach a child who has mild, moderate symptoms differently than that child who has a life-threatening illness. And then, to be perfectly honest, the availability and affordability of the proposed treatment. It really, hopefully not so much an issue in Canada with your national healthcare system, but in the States, insurance companies still determine who can get access to what treatments, and some states, like Arizona, have been quite effective in banding together, setting very clear standards for entry into a consideration for IVIG therapy. So literally, if the Arizona clinic wants to give a child IVIG treatment, they need to have documented a set of symptoms and signs and sort of a prediction of treatment response. They need to have in place what measures they're going to be objectively quantifying to determine whether that child responded or not. And then if the child, after the third IVIG, has not responded by at least 30%, then they move on to a different treatment. So a standardized way of making a decision about whether that child needs to get the therapy, a measure of how sick they are at the time that it's administered, and then a measure of whether or not the treatment worked. Quite reasonable, just as you would do if you were putting a child into a rehab hospital, or if you as an adult patient were starting on a new treatment, you would want to actually not keep going with that treatment if it didn't work. So I thought we'd just do a few cases. It's a little intimidating to read them that way. So I'm going to sum it up by saying this is a child who we would call mild to moderate. And I have to joke because mild to moderate at the NIH, mild to moderate at Mass General or Stanford Clinic is moderate to severe anyplace else. So just put that sort of in an encapsulated form. And that's actually probably appropriate because the truly mild children, if they get treatment with their pediatrician, a course of antibiotics is usually sufficient to abort that episode. And if not antibiotics alone, then antibiotics plus NSAIDs. So that by the time you're thinking, do I need to use steroids or not, the child is much more towards the moderate range of severity. At any rate, this was a 12-year-old boy who had a very abrupt onset of OCD with motor and vocal tics. It came on about 3 weeks after he'd been ill with a strep throat infection. No post-treatment culture was done, but he had completed his 10-day course of antibiotics. And at the time that he came to us, he was doing a lot of touching and tapping rituals. He had to do things in certain numbers of times. He had to do things until they felt just right. And sometimes he would get stuck, and it would take him as long as 2 or 3 minutes to get unstuck from that ritual. But there was never a period where he went more than a few moments at a time before he could move on to something else. Altogether, when you added up all of his obsessional thoughts and all of the time he spent doing compulsive rituals, he was spending about 2 to 3 hours a day, which on the Yale-Brown Obsessive Compulsive Symptom Severity Checklist would put him at the sort of just above a clinical case. In addition to the OCD, he didn't want to leave his parents' side. He's had some definite separation anxiety for both his mom and dad, so it was a little frustrating to him when they were on opposite ends of the house. And so he started at night sleeping outside their bedroom door. They did not let him come into the bedroom with them. And that did not frustrate him to the point that it was intolerable. He was able to get to school, and none of his friends at school knew he had symptoms, very key in determining that he's mild to moderate. His grades had dropped in large part because he was doing some obsessions in his head during the school day, as well as having some newly acquired impulsivity and concentration difficulties. He used to be just a very easygoing sort of surfer dude, and at this point had become very irritable, self-critical, as well as critical of others, and miserable. He particularly was annoyed by the fact that he had to go to the bathroom all the time, which would then set off its own set of rituals, and things would need to be repeated, so just voiding became a frustrating experience for him, and he had to do that several times an hour. He also was having some trouble with bedtime. His review of system was relatively non-contributory, except for the fact that he had had some minor habits over the years that seemed to come and go. Dr. Murphy would call these the microbursts that preceded his full blow. And he was diagnosed with pandas on the basis of that presumed strep trigger, and considered to be a mild moderate case. In contrast, this 8-year-old girl came in with her parents. She also had an upper respiratory tract infection, and I heard yesterday that in Canada, as in the States, if you have a runny nose, they're going to assume you couldn't possibly have strep and not do a culture. Unfortunately, that is actually not the way it works, so we don't know. But she did have a throat culture done after her OCD symptoms had started about a week later, and it was negative, but she had a high ASO. And remember that the ASO just means she's had an infection at some point in the past. She now talks constantly, which is kind of an unusual symptom for an OCD person, until you started asking what it was that she was saying nonstop, and that was she was needing to confess every thought, every behavior, everything that she had. I pointed my toes. What if I thought somebody was pointing at them? She did have intrusive and sexual religious thoughts, despite only being 8, and she was quite bothered by this image that Justin Bieber was touching her private parts with the tweezers, and that God might hate her. She had extreme feelings of guilt, worries about right and wrong. She had worries about the devil coming after her, and in general had a lot of worries about something bad happening. And Paul Grant, our child psychiatrist, and I would spend a long time every patient debating whether the symptom of worrying about bad weather outside, was that an obsessional thought, and we code that under the Y box, or was that generalized anxiety and it goes under the anxiety scale. Again, it probably doesn't matter because this started at the same time as her OCD did. She had a lovely description of the violent images she was seeing. It was like a horror movie playing in her head over and over again, and it was very reminiscent of this boy that we had in the clomipramine diazepamine study, who had the song Indigata Davida stuck in his head, and he literally heard it over and over the entire day. So very strange symptoms can come, and in the old days when they tried to talk about symptom choice and figure out what had caused that particular symptom to present, they sometimes had some very difficult time coming up with an explanation. This would be one of those. She had significance, such as the number 8 meant that she hates her grandparents, so if she saw an 8 anywhere as they were driving down the street, if there was an 8 in the street address, then she would have to do some cleansing and other mental rituals. She developed severe separation anxiety, early morning insomnia, hyperactivity, and she attributed odd meanings to things and had a fear of lying. Her parents reported it appears her brain skips when she talks sometimes. Basically, she just wasn't able to keep her mental processes up with her speech, and it didn't always make complete sense. Her handwriting deteriorated. She had one of those left-sided neglect margin drifts that we showed you yesterday, and she lost a lot of math skills. She had already been working on multiplication tables and actually couldn't do simple addition any longer. She frequently reverted to baby talk, and in addition to continued nighttime accidents occasionally, she was now wetting the bed almost every night and having urinary accidents during the daytime. In this case, she reported, and her parents confirmed, that literally her entire waking day was consumed by her OCD. She couldn't get to school, doesn't play with her friends, and doesn't leave her house. So you're thinking, well, why is she only severe and not extreme or life-threatening? And when I share the next case with you, you'll begin to understand a little bit. But in our minds, the reason that she was severe was, frankly, the degree of distress. She was distressed by these symptoms that she was having, but she wasn't giving that primal panda's cry that we heard yesterday in the videos. And she was able to carry on a conversation with us. And she herself reported that she could get to sleep at night. It took longer, but that her life was miserable, but not to the point that she was feeling suicidal. In contrast, this is an extreme or life-threatening case. The severity overall is actually about the same as the previous young girl, but the thing that changes is just the intensity of his emotional distress, his anxiety, his rage, and as I'll share with you in a moment, his now refusal to eat, drink, and frank suicidal attempts. So anytime you see that, it automatically moves into the life-threatening range. This is a young man who ends up meeting Pan's criteria because he had an overnight onset of symptoms. Previously completely healthy, mentally was doing extremely well, and at that time, he suddenly developed a fear that he would get a stomach virus. His sister had had a stomach virus, but it had been several months before. Nobody recently had vomited around him that he could report, but everything convinced him that it might have a stomach virus on it. If he touched it, he would become contaminated and would have to throw up. He would literally scream when somebody came into the room who might be carrying a stomach virus on him, and is terrified about getting the germs on him, so he was shrinking into the corner and he was very uncomfortable trying to get through the interview with us. He thinks his brother get germs on the food, so they had to eat at different times of the day. He fears brushing his teeth, as the germs might just bounce up out of the sink and stick to his toothbrush. Despite that, he wants to and has to wash his hands many times an hour. He refuses to eat at this point that we saw him and had already lost 4 pounds. Previously had been a good student, but now was unable to leave the house. He had a homebound tutor and couldn't even complete the assignments that she was giving him. Similarly, been a star on his swim team, but couldn't even consider attending a practice because of concerns about contaminants in the pool, as well as a fear that he might have to vomit in front of his friends. And for that same reason, he now refused contact with any of his peers from school. Severe separation anxiety from his mom and also from the house. He is one of those kids that was asking for the reassurance, and the mom had already become entrapped in the compulsion of having to give him reassurance in exactly the right way, or it wouldn't satisfy his obsessional fear, and they would have to go back and forth many, many times. Panic attacks. He had that classic dilated pupils. He also had very adult presentation of his panic attacks with sweating, nausea, feeling of impending dread, a weight on his chest, and just an absolute, complete, quote, meltdown. In addition to those panic attacks, he had rage attacks, and I have seen enough now to understand that they really do deserve different labels, although they appear to be coming from the same thing, the fight or flight, hyper-aroused, hypervigilant state. And he would punch the walls, scream very loudly, and the interventions for the two were quite different. When he was having a panic attack, he actually did need to be held and reassured. When he was having a rage attack, if his parents tried to approach him, it would make him escalate further. He's afraid to go to bed because his thoughts get worse at night. He awakens in the middle of the night, goes into his parents' room to sleep by their bed, and he's having trouble with his school work, as I said. Sometimes he reverts to baby talk, so he's 11, and he's talking like this, well, I get sicky. And that was particularly irksome because that was one of the ways he would ask his mom for reassurance, and when he was asking her in that way, then she was supposed to respond to him as if it was a baby. It was all quite confusing. And as I said, the thing that made us the most concerned about him was there had been an escalation in the severity of his depressive symptoms, his emotional ability, and he had frankly expressed a wish to harm himself. So those are our 3 things, and you can see that they sort of flow between the two. You tend to start, frankly, in any time you find life-threatening, they bump into that category. If you're trying to decide is this severe or moderate, fortunately, the initiation of treatment is pretty much the same for both. Perhaps the rapidity with which you would insist they get into some cognitive behavior therapy might differ, but as you heard this morning, that's also a longer-term process. Before you start any kind of treatments, it's essential that the child have a complete medical evaluation, and so they need to have, if you're going to do anything other than nonsteroidals or perhaps a single dose of oral steroids, in my opinion, they should have a lumbar puncture. A spinal tap should be done to look for other causes of their symptoms in particular, but also just so that you have a baseline in case they don't respond to this early treatment. Excuse me one sec. Now I owe you another minute. Okay, hopefully you read that while I was up trying to get my water. And you heard from Dr. Pasternak about the need for the serum IgA and the fact that at the Mass General, they're actually finding IgA deficiency surprisingly often in these children. Deficiency is not necessarily a contraindication to IVIG treatment. You would need a consultation from an immunologist about how low can it be and still be safe to get the IVIG. And then if you're going to use steroids, you need to make sure that this child doesn't have a hidden infection. The ones that are most easily hidden would be tuberculosis or fungal infections like histoplasmosis and some of the others that can be released with the use of corticosteroids. Immunotherapy, sort of the first line treatment for those mild, moderate cases, is going to be good old nonsteroidals. We still don't use aspirin in children, and I think that this is unfortunate. It would be really nice if we could use aspirin for treatment in these children, because in acute rheumatic fever, aspirin was the only one of the immunomodulatory agents that was effective in reducing the fever as well as making the child feel better. So I'm not brave enough yet to start an aspirin study because of the concern that it might provoke Reye's syndrome, which can be a fatal condition. But it would be lovely if we can prove that the inciting factors of Reye's are truly gone, to consider perhaps reintroducing that to our formularies. Antihistamines, we don't talk about those much in the guidelines, and that's because they tend to not be used, but actually, Melissa had the allergic shiners. If you saw those in a child, and or if the pattern was such that they were being provoked by mold allergies in the school or at home, you would want to get that source of immune stimulation under control. And lost my mic and lost half the slides. Half of them are still there, but that's okay. The mic's back, so that's good. The immunotreat. Oh, 2 seconds. The whole thing's going. It said in 2 seconds it will turn off the projector. Help. Well, if it goes off, then you're really going to be bored. We'll be back. In the meantime, we'll just keep going. IVIG for the moderate, we were talking about antihistamines. You have to use both H1 and H2 blockers. H2 are the most common antihistamines that we think about. The others you typically would use as an anti-acid, so a combination of those two medications may be more helpful than one by itself. Oral steroids, even for mild cases, might be indicated, and here the best equation is if the child's symptoms are similar to what you would treat asthma with steroids, then you could use a short course of oral steroids. We're going to go through all of these in more detail. So nonsteroidals are ibuprofen, naproxen, other medications, and they are a treatment of choice for the mild to moderate cases early in the episode. And early in the episode is in that first 2 weeks to perhaps as long as a month. You'd prefer to use naproxen, but the liquids taste really nasty, so you may be stuck using ibuprofen, and ibuprofen has to just be given more frequently. Its half-life is such that, like penicillin, you need to give it in equally divided intervals. So sometimes the child would need to take it like right before they go to bed, or I've had parents who've even woken the child to take it. When you give the naproxen, any of the nonsteroidals, you're worried about two things. You're worried about inducing kidney damage, so they need to have lots of water with this to make sure that they're well hydrated. And the second thing is that it can be quite irritating to the stomach, and they can get a gastritis. So give it with food whenever possible, and fluids. Continue treatment for 10 to 14 days at treatment doses. Do not do like one of my moms was doing, and that was anytime the child's behavior increased in severity, she was popping an ibuprofen at him. No, it's not like Tylenol for a headache. It's a anti-inflammatory preparation, and you give it on a regularly scheduled dose, not a PRN or as needed. And you're going to want to make sure that the child doesn't develop tummy pain, hematuria, or a much more rare condition, pseudoporphyria, which is basically just a fake problem. Steroids are probably preferred just because they're much more effective than the nonsteroidals. And because they're more effective, they have more side effects. So it's always a risk-benefit ratio. It's determined on your own child's symptom severity, your own child's chances of benefiting from the treatment. And you weigh that, and you continue to weigh it as the therapy goes on. A short course of oral steroids is incredibly common in pediatrics. It's given so often for asthma that it's just sort of a non-brainer, we would say. And a steroid burst may be appropriate even for the mild to moderate, mildly affected individuals. If you move to the point where you're deciding that you need to give a long course of steroids, a full month at high dose, and then a 1 to 2 month taper down from that high dose, that's a decision that should be made more cautiously, because your chances of having side effects, particularly suppression of the adrenal steroids and a cushion-cushion-oid-like appearance, become problematic. Weight gain is also more of a problem there, as is the fact that you've had more effective suppression of the child's own steroid ability to respond to a stressor. So they're more susceptible to getting an infection, and they're more susceptible to other difficulties. Probably the main thing that holds us up in a lot of our kids, particularly those who are coming in with a very hyperactive, agitated, impulsive, behaviorally disinhibited state, is the fact that in neurotypical children, asthmatics who are getting steroids, they can have a steroid-induced mania where they literally cannot sleep, they don't want to eat, they're all over the place. In very severe cases, they can develop psychotic symptoms. You can imagine that you don't want that happening to your child with pandas. So that's held us back. Fortunately, we were comparing our experiences with use of steroids in the PANS cohort, and it does not appear that that is a common side effect. If it's occurring even uncommonly, we're not noticing it that much. So I don't think we're as worried about it as we would have been a few years ago before we had as much experience. IV methylprednisolone, this is, even though it's not on a white background, this is actually one of Jenny's slides as well. And at the Stanford Clinic, they use monthly IV methylprednisolone for 1 to 3 months, because it's used in other inflammatory brain disorders as well as autoimmune diseases as part of an induction therapy. It basically gets that system rebooted as quickly as you want it to, and it seems to be better tolerated in their experience than the oral prednisone. You want to do it at a time when everybody's well in control of the situation, because you may well see an escalation of the symptoms for the next 3 to 4 days, but then they will rapidly come back down, and that is not universal, so it's not something that every child's going to experience. One big advantage when I talked about a very realistic determinant of what we're using for immune therapy is whether or not it will be paid for. The fact that IV methylprednisolone is used in so many diseases, and more importantly, is dirt cheap to the insurance companies. They don't give you a hard time about doing it. And if you're waiting to get approval for IVIG, many times it can get that child into a situation where they can tolerate that weight. And probably most important is that little line about test of concept. If you see a beautiful response to the IV methylprednisolone, it's really very confirmatory that you're thinking about an inflammatory brain disease and that you're on the right path with using immune modulating treatments. Unfortunately, the effects don't last, and you can't maintain those monthly bursts of IV methylprednisolone over the long term because of the intensity of the treatment. But if you can do this short course and see a response, then you know that IVIG has a good chance of being helpful. The side effects were studied at the Stanford Clinic, and they did see them in nearly half of their children, or half of the courses of oral corticosteroids that were given. And they ranged from an increase in the symptoms of OCD, anxiety, emotional lability, irritability, more trouble with sleeping and tics and all the things that we had been worried about and were supposed to be treated with the steroids. But none of these were severe enough that they were felt to impede ongoing treatment. And of those who had longer-term steroids, the 1-month course, 8 had weight gain or cushingoid features, with sort of an even distribution between those who gained an unacceptable amount of weight and those who became cushingoid and those who had both. None of the children developed any of the permanent side effects that are of concern in long-term corticosteroid use. So we're going to turn now to IVIG, intravenous immunoglobulin. And it's a reminder for those of you who maybe aren't IVIG savvy that it is a pooled human donor product, and the manufacturer, Talocris, Octagam, whatever pharmaceutical company is changing this collection of immunoglobulins from up to 20,000 human donors into a product that can be infused into your child. There are many, many steps along the way, starting with the collection of a clean, uninfected blood sample. And at the NIH, we unfortunately had our Sydenham, Korea study underway when a single lot of of the Baxter product that we were using of IVIG was contaminated with hepatitis C. There were no tests yet for hepatitis C, and we gave one of our boys an infusion of IVIG that included hep C. So we basically gave him hep C by our treatment. PANDAS is a temporary illness, Sydenham, Korea is a temporary illness. Hep C at that time was a lifetime illness, and so that was not a fair trade. I keep that in the back of my mind all the time. Praise the Lord, sorry. Fortunately, he was able to participate in the hep C treatment trials at the NIH, and he got medication, has been cleared, so it has a happy ending to that story. But as parents, when you're thinking about this and you're pursuing IVIG, and particularly when you actually haven't seen a lot of benefit from it, hold that story in the back of your mind and say, okay, well, if there's another bad bug out there, is the chance that he's going to respond greater than my worry about that? Now I've just given you new obsessional worry, and I apologize. So, yes, thank you. Yes, there's tests for hep C, D, many of the HEPs now, and hepatitis is and more importantly, because of HIV screening and just the incredibly careful screening that's done of donors, from which these blood companies have got to get their products. So it is very carefully regulated, and thank you, Robert, you're right. There are tests, and you don't have to worry about that one at all. In fact, there's no known bug right now, am I right, for which we would have concerns that it would be transmitted through a blood transfusion or as a consequent, an IVIG infusion that we don't have a test for. So remote worry, do not add it to your obsessions list. You have other things to worry about. However, it does bear talking about the fact that the donor pool affects the utility. And one of the things that increasingly difficult with the increased use of IVIG and the fact that they've had to draw from different communities is that you're not getting sort of local product. You would be happiest if you could get IVIG from Saskatoon residents, because they would have been exposed to everything your child's being exposed to, and then that should be more effective. The other thing that influences it is the way the product is prepared. And when I show you the results from the IVIG study at the NIMH and Yale did, one of the questions that we had was Talacris's product too clean? Was some of the reaction to the product that we had seen with our previous trial part of the therapeutic benefit? And the answer to that is unknown. But again, risk-benefit, I'd rather have really clean IVIG going into my child, even if it perhaps has a less efficacy. Dr. Kovacevic, Dr. K, to those of you who are on the internet, uses 1.5 kilograms per kilogram, and we actually tried to use that at the NIH because that is the dose. He was a neonatologist, so he was used to calculating blood volumes and volumes of immunoglobulins, and calculated that that's actually the replacement amount. And so if you read any of his reports, that's why he uses 1.5 grams. That's still considered high dose. The thing that you would want to avoid is any kind of low dose administration of IVIG, because that may actually exacerbate the condition rather than improving it. Everybody else uses 2 grams per kilogram, and the rationale for that was the fact that that was the dose that was proven to be effective in Kawasaki's disease, probably the closest pediatric equivalent to Sydenham chorea and rheumatic fever, to PANDAS, as well as in GBS, Guillain-Barré syndrome. So that's given as 1 gram per kilogram per day on each of 2 consecutive days. IVIG not only has that risk of transmission of an occult infection, but it also has a risk of anaphylaxis just to the product. You're giving a very immunoreactive product directly into the bloodstream and can trigger off an anaphylactic reaction. For that reason, there's a very carefully prescribed protocol where you start quite low dose, need to be checking vital signs. Many of the home infusion as well as center infusions will have pre-medication with Benadryl, Tylenol, other medications to prepare the child. Despite that, most children will have some kind of, side effect of the administration. They just don't feel well the night that they get their infusion. And by the second morning when they wake up, they feel fine, but that night they don't feel very well again. So we would always keep them in the hospital the night after the infusion, or a home center. They would want to be monitoring them next morning. More about 1 in 4 to 1 in 10, depending on what product's being used, what center's doing the infusion, and what the formularies are, about that number will develop symptoms of what we call aseptic meningitis. That's basically a sterile inflammation of the meninges, the lining of the brain. And a bacterial meningitis is an incredibly serious disease, can be fatal. So if a child develops very severe headache, nausea, vomiting, and particularly if the headache is postural, so that they feel better when they're laying down than they do when they sit up, then you would want to have evaluation by your clinician immediately to rule out an infectious meningitis. If it's an aseptic meningitis, likely they might try some steroids to decrease the symptom severity. Therapeutic plasmapheresis, in our papers we always called it PEX for plasma exchange. It's also abbreviated as TPE, or just spelled out as plasma exchange. And basically this is a procedure in which albumin is exchanged for the child's plasma through a machine, and the kids would call it the blood cleaning machine, and they'd go down and get hooked up to the blood cleaning machine in the apheresis unit, and they would be on that machine for 2 hours while their blood is taken out, spun in a centrifuge, and the plasma is pulled off along with all of the antibodies, complement factors, everything else that's in the plasma. And that volume is replaced with albumin and saline, and also the child is given back their red cells, white cells, and platelets. It requires a very large vein for this to happen, as you can imagine, because you don't want to damage those cells as you're taking them out of the body or having them flow back in. And so only children who are 12 or above are probably big enough to have large enough veins. Remember the boy with the amazing shrinking caudate and how I said we had to hold his arms? Well, he was a gymnast, and he had the best honkin' antecubital veins we'd ever seen. So he was able to do all of 5 of his procedures with peripheral lines. There were only 2 other children in that original cohort that could get away with that, and instead what they would have was central lines placed. We used the internal jugular at the NIH just because it put the bandage up on the backside of their neck and they didn't have to bother with it. The Georgetown group has used in femoral lines, and the downside of that is that you have to keep the child in bed for that entire period, which at Georgetown was a full week. So that's a long time to lay in bed with a sandbag on your groin. And they had one very unfortunate situation where a child had been extremely disinhibited and managed to pull his line and cause some significant damage. So this, again, like IVIG, is not something that we as clinicians recommend lightly, but the reason that we're willing to take those risks, to minimize those risks by doing everything we can to keep your child safe, is because it's so dramatically effective. Whether the central line's in the neck or the groin, the child is going to be in the hospital for the duration of the treatment. NIH's protocol is 5 single-volume exchanges over a 10-day period. Georgetown's protocol is 4 1.5-volume exchanges over a 6-day period. And what they end up with is about the same amount with more time for equilibration in the NIH protocol. Side effects, we've talked about the risks sort of associated with having that central line in there. There's also a risk of infection with this. That same Sydenham Korea study, I think it was just a real test of our ability to go on, because the NIH pharmacy was trying to save money. They were reallocating large volumes of albumin into smaller bottles. One of them had become contaminated, and we gave a child a gram-negative sepsis by direct infusion into her bloodstream. So that should never happen to you. That really was a unfortunate lifetime experience, and the NIH pharmacy fixed it, sent out a warning to every other pharmacy so it could never happen again. And the sterility is maintained on the infusates. However, it's on the consent form that you'll be signing, so I just wanted to share that with you. Now, there are procedure-associated discomforts. None of these is life-threatening. Even if the machine completely malfunctioned, there's never more than a tolerable amount of blood out of the child at any one point in time. So for an adult, it would be a full unit, just like you would donate if you were going to the blood bank to donate blood. In smaller children, it might be as little as half a cup at a time would be out of their body. So if that was lost, they would not become too anemic or have other difficulties. However, just going through the machine and the anticoagulants that are used, the calcium levels in their blood will be changing rapidly, and they'll start complaining about a little tingling around their lips or maybe tingling in their fingertips. That's just a sign that you have to pop a Tums in their mouth. They chew the Tums, and it disappears within a few minutes. It's pretty cool. Well, again, Dr. Tiedemann and I think are medical nerds. It's only cool to us. I promise I wasn't hoping that it would happen to the child. It was just cool that I could fix what was wrong with them with the Tums. So, sorry. Plasma exchange and prophylaxis, in our experience, was enough. We cured our kids with PANDAS, and I'll show you that slide in a moment. In PANS, that is not the experience. And so the question are the risks of a plasmapheresis sufficiently overcome by the potential for a benefit of a 60 to 65% temporary reduction in symptoms, and how long will that temporary reduction be maintained? And that's a question that still needs to be answered in a larger study. So the trial that all of this is based on, we do have 2 studies giving empiric data on the utility of IVIG and plasma exchange, and only one for plasma exchange because we attempted to do a replication where we actually were putting central lines in children and doing sham apheresis. The blood came out. It didn't actually ever go through the apheresis machine, went back into them. It was all behind a curtain. It was all very Wizard of Oz-like. And frankly, we did 4 children, 2 of whom had gotten placebo. Sorry. And I am a pediatrician, and I couldn't go on. I terminated the study because there was no way I could put another child through that experience of 5 days in hospital, central line placement, and having nothing benefit. So I'm going to get to another one where it doesn't make me cry, but if you ever wonder why that wasn't replicated and why I was so furious when Harvey Singer criticized the study for inadequate controls? The reality is the NIH pharmacy randomized all the children. We had no choice about who got assigned to what treatment group, so you had an equal chance of being assigned to the placebo IVIG, shown here as sham IVIG, as you did to active plasmapheresis. And for that reason, we compared the results, and our plasmapheresis group, shown on the right, had a 65% reduction in symptom severity over the course of the 1 month. Actually, it was only 2 weeks from hospital discharge until they came back to us. They maintained those treatment gains and had even more over the course of the next year with adequate prophylaxis. And literally, the children were rescued from their illness in that study. As you can see, a number of them went down to completely asymptomatic. In contrast, the children who got the sham IVIG left the hospital. 9 of those 10 children thought they'd gotten the real stuff. If you are a 7 or 8-year-old child and somebody gives you Benadryl and Tylenol for 2 days and puts IVs in you and keeps you in bed, you don't feel good when you leave your hospital. And 9 out of the 10 of the children and their parents rated, they thought they had gotten active treatment. And yet when they came back a month later, they had absolutely no improvement in their OCD symptoms, anxiety, or their global severity scores. In contrast, those who got real IVIG had a 45% reduction in symptom severity. Now, I told you about the problems we had in the Sydenham Korea study. Fortunately, we had no severe adverse effects in this PANDAS study at all. But the results in the Sydenham Korea were similar, except instead of using placebo, because prednisone was an acceptable treatment for Sydenham's, it was our third arm instead of a placebo. So we had kids randomly assigned IVIG, placebo, or plasma exchange, and that was considered acceptable because we could have blinded raters. We did videos of the Korea before and after treatment. Blinded raters rated those. Same results. Plasma exchange was much more effective than IVIG, which was much more effective than prednisone. And that study is actually considered sufficient evidence on its own with fewer subjects as justification for use of both, either IVIG or therapeutic plasma exchange for Sydenham Korea. And I think it's totally because of the controversy that continues to surround PANDAS. Here's the amazing shrinking caudate again, 20% reduction in symptom severity, in the size of his caudate, 98% reduction in his symptom severity. He went from spending nearly every waking moment doing these very convoluted rituals and having terrible obsessional fears to completely symptom-free. He received plasmapheresis. This young girl actually got IVIG before treatment. That was her picture of herself or a friend, and during the episode she literally lost the ability to draw and regained it within a couple of weeks after treatment. I'm going to share one vignette. I'm not sure how well it'll help, but it's much easier to see this degree of response in a child with Sydenham Chorea. Remember our girl who had the chorea mole yesterday? She was the little rag doll that had to be helped up out of the chair. Watch her hands this time. See how it kind of moves? But she's just very floppy, flaccid. She was from Los Angeles, so we spent the 2 weeks she was with us in the hospital working with our rehab medicine department to get her a belt for her parents to help her get up out of the chair, wheelchair, everything to take home with her to one of actually the worst neighborhoods in LA. And with some trepidation, discharged her to the hospital, brought her back 2 weeks later. We did not give her any medications. Haldol is sometimes used for the movements, but because her main problem was the mole rather than the chorioathetoid movements, she did not get that, and actually had not used her treatments, her chair or belt at all, because within 3 days of getting home, this is how she was. She was completely back to being able to walk, rise from a chair by herself. She could talk again, she could feed herself, she was doing all her activities of daily living. And that kind of sort of Lazarus arising, remarkable cure is what we were seeing in psychiatric symptoms among our children who had PANDAS. In contrast, our Yale NIMH placebo-controlled trial failed to find a significant difference between the IVIG. And I'm not going to sound like sour grapes and tell you all they actually were true reasons that we failed to make this experiment. There's only one that's really salient, and that was the fact that our IRB and then Yale's added to this problem, determined that it was unethical for a child to receive placebo without having the opportunity for active treatment, and therefore they determined that any child who had not had at least a 30% improvement in symptoms at the end of the blinded phase would be eligible for open label treatment. Now, I'm the mom of 3 girls, and if I put my child in an NIH study where they had a 50-50 chance of getting placebo, and I knew they could get active treatment with IVIG, I would be really hard-pressed to rate accurately a 30% improvement in symptoms. And it even got worse than that because the Yale was doing the ratings and NIMH was the clinical team. We would be in the room, the nurses would be like, wow, that kid's so much better. He's separated from his mom. He wasn't over at the sink washing his hands when I walked into the room. He's happy, he's smiling. You could literally see the difference on their faces. Didn't matter, they would still be eligible for open label treatment. And out of this study, 25 of the 35 participants got open label IVIG, despite the fact that a number of the children who received IVIG had had fairly significant symptom improvement. So one problem was an underrating of improvement. The other problem was that we hadn't controlled for infection exposure, and so some of the children actually got started on their antibiotics just the day before they got their IVIG infusion, and 2 of them were antibiotic responders, and of course, bad luck being what it is, both of them were actually in the placebo group. So they had almost complete reduction in symptoms after receiving placebo when actually what they had was an antibiotic response. So I know Stanford, I think Mass General, and others are working with Octagam Pharmaceuticals to do a phase 3 trial of IVIG that's going to correct all of these mistakes, and the study design has taken a long time to get right, but I'm very excited about the fact that they've controlled for these sort of subjective biases, recall biases, and everything else, and I am very hopeful that they'll see in their closed double-blind phase, the phase that counts when you report a study, what we saw in our open-label phase in this trial, and that was that same reduction, in this case 55% on average. At 6 months, more than 80% of the children were improved into the subclinical to very mild range of symptom severity. Many of them were taking SSRIs or doing behavior therapy, but the largest change in their improvements had happened during the period of the study. I mentioned yesterday, and just here's the data to suggest that the combination of a positive ANA and a positive calcium modulin 2, kinase 2, may be able to predict which children are more likely to respond to IVIG, and therefore it's become sort of, at least an ANA is a standard test that I do on the kids participating in our trials. Here's a 12-year-old boy. How much? Oh, I'm out of time. Never mind, we'll look at that during Q&A. Because I need you to understand one very, very, very important thing. I've just shared with you how uncomfortable it made me to do sham apheresis. Well, it was equally uncomfortable to sort of jump out on that leap and say, well, maybe we just accidentally found a treatment for non-PANDAS OCD. We better see if it works. This was also actually a test of concept. Is there anything immunologic about this, or is it actually putting the child in the hospital, holding them prisoner for 2 weeks? It was a forced inpatient hospitalization, not psychiatric, but inpatient hospitalization, and maybe that was what caused the improvement for our plasmapheresis group. So Rob Nicholson is the first author of this paper, but he, Judy Rappaport, and I took 5 moderately severe children with non-PANDAS OCD, hooked them up to the plasmapheresis machine, did 5 single volume exchanges, exactly the same protocol we had used for our PANDAS children, and found absolutely no improvement in symptoms. Peter Hoekstra and the group in Denmark used IVIG in a similar manner for non-PANDAS Tourette's syndrome patients, found absolutely 0 improvement. So If I didn't scare you enough before with side effects, I want you to hear this now, that if you are seeking immunotherapy for your child and you in your heart know that the symptoms actually came on over a period of days or weeks, you are not doing your child a favor by presenting their history as if it was a PANS PANDAS, because immunotherapy will not help them, and it will cost you time that you could have been using to do something more helpful. Okay, I'll get off my soapbox and just put it in yellow words, highlighted words. Immune therapy does not help regular OCD, and because of its side effects, the risk-benefit ratio is absolutely not in favor of its use. So to summarize, mild cases, non-steroidals, antibiotics, you're going to hear about in just a moment. And absolutely imperative, get them into behavior therapy, use SSRIs or anxiolytics as needed. Moderate, you're going to move to oral steroids, perhaps IVI steroids and IVIG. Severe cases, you're more likely going to be using IVIG, IV steroids, possibly plasma exchange if it's available. And in severe life-threatening cases, you want to do things that are moving as quickly as possible. So when Dr. Frankovic were here, she would probably say, well, if I ever use plasma exchange, I only use it with other things to cover after that effect. And so you would be moving towards a different level of treatment. And at that point, to be perfectly honest, you need to see Dr. Rosenberger, immunologist, rheumatologist who has a lot of experience in using these treatments for different diseases, because you want somebody who has the most experience in their use. Just close by saying that we were very excited about rituximab about 4 or 5 years ago. Stanford had a good response with use in the first few patients that they tried it on. And since then, the enthusiasm has waned, if not disappeared, because it takes a long time to help. This is an episodic, relapsing and remitting illness, and so you never really know if a treatment takes up to 6 months or longer to benefit the child. Was it the rituximab, or was it just the natural course of illness? And certainly introducing in a growing child who's in that cesspool of strep that we talked about at the school, rituximab, which depletes your B cells and depletes a very important part of your immune system from fighting off infections, it's not something you should be doing lightly. So absolutely, that one has to be given by a specialist experienced in its use, very, very careful consideration. And I am very hopeful with all of the new biologics that are being released now, with some of the studies that our consortium is doing to try and better pinpoint where in the immune system the abnormality lies, that we'll be able to come a year or two from now and give you a much better option, the rituximab. All right, so lessons learned, and I just finished this off by saying, sometimes the kid gets the IVIG at the wrong time. And you want to do your best to make sure that they're healthy going in there and that you can keep them healthy for the first week or two after they've gotten the IVIG. So if you've waited forever to get that IVIG appointment, but you've had a cold run through your house, it actually is worth it to put it off for another week or two, because the Stanford experience has shown that if the child has an intercurrent infection, if they have a viral infection at the same time they have the IVIG, it's just not going to be very helpful. And then you're going to think that IVIG doesn't work. And that we do use that full course press of combination therapy. And so, again, it needs to be done with a lot of help and support. I asked, and neither of the others are talking about the fact that we also try to optimize vitamin D levels. That's just based on an emerging literature suggesting that vitamin D helps to stabilize the immune system, and that because children spend all their day indoors playing video games or going to school, their vitamin D levels are likely to be not sufficient. So get the vitamin D up to normal. Melatonin may be helpful. If you're given the antihistamines in conjunction with the NSAIDs, give the Benadryl at nighttime, and that may help them asleep as well. And the bottom line is, when we refer for behavior therapy, we're not just sending the child, we're sending you as parents and clinicians. Actually, the more we can learn about it, the better too. Because the key to handling PANS PANDAS is to stop it where it is today. As soon as that child begins to have learned behaviors, and those become reinforced over and over and over again, the disease becomes entrenched, our immune therapies aren't going to work as well, and more importantly, the chaos in the home just builds to a completely unacceptable and unlivable level. So the first thing that happens in our kids that go to cognitive behavior therapy is the family sits in for the evaluation, finds out what kinds of symptoms are happening, and then maybe the child goes with the therapist if they can separate. If not, one parent comes back and begins to learn ways to effectively not engage in those behaviors. So support for the tough love by the parents. Again, just a mental picture to put in your mind. Howard Hughes is the ultimate example of how when you have people kowtowing to your obsessive compulsive symptoms, you're going to end up a prisoner of your disease. So with that, I'll close, and I did take too much time, and I'm sorry. Started late, ended later.
Thank you, Dr. Swedo. I think we'll all forgive you for your